All right, let's jump right into it. Welcome to this explainer. Today, we are taking an absolutely fascinating journey to the very first heartbeat and well beyond. As you probably know, the heart is the very first functional organ to develop in the human embryo. By building a step-by-step, highly board-relevant visual roadmap of early cardiovascular development, we're going to uncover the exact origins that are absolutely crucial for your upcoming exams and, of course, your future clinical practice. To organize our timeline, we're going to follow a strict chronological menu today. We'll start with progenitor cells and heart fields, move right through embryonic folding, check out the layers of the heart tube, decode the cardiac looping process, identify the primitive tube derivatives, and finally wrap up with clinical defects and the venous system. Mapping time to 3D space is the secret to mastering embryology, so this structure is going to drastically lower your cognitive load. Okay, let's dive into Section 1, Progenitor Cells and Heart Fields. Let's rewind the clock all the way back to the middle of the 3rd week of gestation. At this point, the growing embryo is getting too big to survive by simple diffusion alone. It desperately needs a dedicated delivery system. Taking a bird's-eye view of the early timeline, the milestones happen incredibly fast. On day 16, progenitor cells migrate. By day 22, two separate tubes fuse together and we get our first heartbeat. Day 23 kicks off cardiac looping, which completely finishes just a few days later, by day 28. Definitely bookmark these exact days in your mind. It all starts on day 16, when progenitor heart cells initially lying in the epiblast migrate right through the primitive streak and into the lateral plate mesoderm. As they move, some of these cells gather to form a very distinct horseshoe-shaped cluster. We call this the cardiogenic field, and it's positioned just cranial to the neural folds. Now here's a massive, high-yield concept you absolutely must differentiate for your board exams: the specific origins of our cardiac structures. The primary heart field, or PHF, goes on to form portions of the atria and the entire left ventricle. Meanwhile, the secondary heart field, the SHF, is responsible for building the right ventricle and the outflow tract, while also chipping in a bit to the atria at the caudal end. Moving right along to Section 2, embryonic folding and tube fusion. We are now entering an incredibly dynamic phase of development. It's essentially mechanical spatial gymnastics, where flat 2D layers literally transform into functional 3-dimensional tubes. There are two distinct folding axes happening at the exact same time. Lateral folding brings the sides together to create a single heart tube. Meanwhile, cephalocaudal, or head-to-tail folding, physically pulls that tube downward, placing it right into its proper home in the thoracic region. If you were to look at a cross-section of this lateral folding, you'd see the two separate endocardial tubes being pushed closer and closer together. By the 22nd day, they fuse perfectly. What we're left with is a single, continuous heart tube made up of an inner endocardial layer and an outer myocardial mantle. Now, what's really interesting about cephalocaudal folding is how forcibly it relocates the heart and the primitive pericardial cavity. It starts way up in the cervical region, so essentially in the embryo's neck, and gets physically shoved downward until everything rests securely right where it belongs in the thorax. All right, Section 3, layers of the heart tube. So, now that our singular tube is locked into the thorax, what exactly is it made of? Well, it's composed of 3 essential layers. The inner endocardium forms the internal lining. Then you have the myocardium, which forms the muscular wall. And a very highly tested fact here is that the myocardium secretes cardiac jelly, a super important layer of extracellular matrix that's rich in hyaluronic acid. Finally, the epicardium covers the very outside. These cells actually migrate from the dorsal mesocardium as it disappears to create the transverse pericardial sinus. Section 4, the cardiac looping process. Definitely pay close attention here, because days 23 through 28 represent the most spatially complex and heavily tested phase of early heart development. As our heart tube lengthens, it basically runs out of room, so on day 23 it starts to bend. You have got to memorize these specific directional movements. The cephalic, or top portion, bends ventrally, caudally, and to the right. At the exact same time, the atrial, or bottom portion, shifts dorsocranially and to the left. These opposing movements are exactly what contorts the elongating tube into the vital cardiac loop. And just to prove this isn't just some abstract theory we've cooked up, scanning electron microscopes capture the stunning physical reality of this. Inside the developing embryo, strict spatial constraints literally force the anatomy to fold in on itself, meticulously creating our distinct right and left-sided structures. As this intense looping wraps up around day 28, the conotruncal portion of the heart tube gradually shifts to a much more medial position. This happens because two transverse dilations of the atria start bulging outward on either side. They're essentially physically pushing the anatomy into its mature final alignment.
Which brings us to Section 5, Primitive Heart Tube Derivatives.
Now, matching these primitive structures to what they eventually become in the adult heart is arguably the most board-relevant concept in this entire explainer. It's super helpful to mentally capture the primitive heart tube as a vertically aligned stack. From top to bottom, we have the aortic roots, the truncus arteriosus, the bulbus cordis, the ventricle, the atrium, and finally the sinus venosus down at the base. Seriously, lock this structural alignment right into your visual memory. Let's walk through exactly what these segments turn into. The truncus arteriosus forms the roots in the proximal portion of the aorta and the pulmonary artery. The bulbus cordis takes on a lot of work, forming the right ventricle and the outflow tracts of both ventricles. Meanwhile, the primitive ventricle segment matures into the left ventricle. Crucially, the narrow little junction between the left ventricle and the bulbus cordis is known as the primary interventricular foramen. Finally, Section 6, Clinical Defects and the Venous System. Let's transition from textbook development into clinical reality. We've seen just how perfectly coordinated those day 23 looping mechanics have to be. So what happens to our patient when those precise, intricate spatial gymnastics actually fail to execute correctly? Well, a chest X-ray brilliantly illustrates exactly what can go wrong. In these cases, you'll spot major anomalies. The stomach bubble might be entirely on the wrong side. But more importantly, the prominent shadow and contour of the heart are sitting distinctly over on the right side of the patient's thorax, rather than on the left where it belongs. This exact clinical presentation is known as dextrocardia. It's a direct result of a mechanical failure way back on day 23. Instead of the heart tube looping correctly to the right, it abnormally loops to the left. Interestingly, this defect often coincides with a condition called situs inversus, which is a complete mirror image reversal of asymmetry in all of the body's internal organs. Just before we conclude, let's quickly summarize the venous inflow system down at the very bottom of our primitive tube, the sinus venosus. During development, it's receiving blood from three crucial veins. You have the vitelline vein, the umbilical vein, which carries oxygenated blood but actually disappears after birth, and the common cardinal vein, which sticks around and goes on to form the adult cabal system. And there you have it. We've mapped out the precise, step-by-step formation of the early cardiovascular system. It truly highlights the absolute delicate precision of embryology, doesn't it? The fact that one microscopic misdirection of bending on day 23 can physically alter the rhythm and placement of a human heart for an entire lifetime. Keep this visual framework handy as you move forward in your studies. But it does leave us with a pretty fascinating question to ponder. If one microscopic shift on day 23 defines the heart, what other invisible cellular choices are secretly dictating the rest of our anatomy?
Hey everyone, and welcome to this explainer on the embryology of the cardiovascular system. For all you focused learners and second-year med students out there, we're about to tackle one of the most high-stakes, incredibly precise developmental processes in the entire human body, the septation of the embryonic heart. I mean, the transformation from a simple, primitive heart tube into a fully functional, four-chambered pump is just an absolute marvel of biology. So get ready, because we're going to master the anatomy, the developmental timelines, and some really vital clinical correlates today.
Okay, let's dive right in. Here's our roadmap for today's explainer. We'll be looking at the mechanisms of cardiac septation, atrial septum development, differentiation of the atria, and AV canal septation. Then, we'll tie it all together by applying this normal embryology to clinical pathology with teratogens and atrial septal defects.
Section 1. Mechanisms of cardiac septation, setting the stage. Let's start by looking at the normal physiological mechanisms of how the heart divides, because we really have to master the baseline before we can understand the defects. To truly appreciate this process, you really need to understand the incredibly narrow developmental window we're dealing with here. The major septa of the heart actually form between the 27th and 37th days of development. Think about that. It's literally just a 10-day window. During this crazy rapid period, the embryo grows from a tiny 5mm speck to about 16 or 17 millimeters. So you can imagine, any little disruption during this specific 10-day stretch can lead to some pretty profound structural abnormalities.
So, what are the primary building blocks for dividing up these chambers? They're called endocardial cushions. Basically, these are actively growing ridges of tissue that approach each other, and they eventually fuse together to form a solid septum.
We primarily see this vital mechanism happening in the atrioventricular canal and the outflow tract. Now, what's really fascinating here is visualizing how this all kicks off. Early on, the heart tube is just myocardium on the outside and endocardium on the inside, right? And they're separated by this layer of extracellular matrix, or ECM. You can see here how the endocardial cushions start out as physical expansions of this extracellular matrix. Once that matrix expands, cells actively migrate right into those cushions and start to rapidly proliferate.
All right, pay attention here, because this brings us to a massive, high-yield exam point, the cellular origins of these migrating cells. They are not all the same. The cells that migrate into the cushions of the atrioventricular canal, those are derived straight from the endocardium. But the cells populating the outflow tract cushions have a completely different embryological origin. They're actually derived from neural crest cells. You definitely want to lock that distinction in your memory.
Moving on to Section 2, Atrial Septum Development, a step-by-step mechanism. Now that we know how the cushions form, let's look at the complex sequential division of the common atrium.
This is basically a beautifully choreographed dance of tissue growth and programmed cell death. First up, you have this sickle-shaped crest called the septum primum. It starts growing downward from the roof of the common atrium. As it reaches down toward those endocardial cushions, it leaves a little opening at its lower rim, which we call the ostium primum. Eventually, tissue from the cushions will grow to close off this ostium primum. But, and this is absolutely critical, before that closure is completely finished, a new opening has to appear higher up in the septum primum. We call that the ostium secundum. Why? Because we have to maintain free blood flow from the right to the left primitive atrium. That is vital for fetal circulation to actually work.
Following that, a second structure appears, the septum secundum. And you can see brilliantly here how it grows down and begins to overlap the ostium secundum. Notice how it doesn't seal it completely shut? Instead, that specific overlapping arrangement leaves an opening that creates the all-important oval foramen, or foramen ovale. Basically, it acts as a crucial one-way flutter valve, allowing oxygenated blood to shunt from right to left.
This detailed cross-section really puts the whole morphological progression together for us. You can clearly track all the spatial relationships here. You've got the downward growth of the septum primum, the programmed cell death creating the ostium secundum, the fusion with the endocardial cushions, and then the overlapping descent of that thicker septum secundum. It gives you a perfect structural map of how one single common chamber physically becomes two separate, functioning atria.
Section 3, Differentiation of the atria, left versus right. Let's see how this all builds into the final anatomy.
So it's not just about building a wall between the chambers. The left and right atria actually mature into very distinct anatomical forms based on where they came from embryologically. On the left side, a single embryonic pulmonary vein develops. As the heart grows, this vein and its branches are literally incorporated right into the wall of the left atrium. That's what gives the adult left atrium its large, smooth-walled appearance. Conversely, the right atrium has a dual origin. The original embryonic right atrium turns into the heavily trabeculated portion. That's where you find the pectinate muscles. Meanwhile, the smooth-walled section of the right atrium, the sinus venerum, originates from somewhere else entirely. It comes from the incorporation of the right horn of the sinus venosus. Contrasting these origins is super helpful for understanding the adult gross anatomy.
Section 4, Atrioventricular canal septation, dividing the flow. Now we have to divide the main pathway between the upper and lower chambers. Early on, the atrioventricular canal actually only gives access to the primitive left ventricle, and it's separated from the bulbus cordis by a bulboventricular flange. But as development keeps going, the entire AV canal physically enlarges and shifts over to the right. Because of this rightward shift, blood passing through the AV orifice finally gets direct access to both the primitive left ventricle and the primitive right ventricle.
Once the canal is properly aligned, the actual division happens in these 4 exact sequential steps. First, 2 major mesenchymal cushions. The anterior and posterior AV endocardial cushions show up at the borders of the canal. Then, 2 more lateral cushions form. The real magic happens when the anterior and posterior cushions grow toward each other and ultimately fuse. That critical fusion is what completely divides the common canal into your distinct right and left atrioventricular orifices.
Section 5. Teratogens and heart defects, clinical correlates. So far, we've covered the normal, textbook embryology. But what happens when these exact mechanisms get disrupted?
Well, here's a pretty sobering statistic. Heart and vascular abnormalities actually account for a full 1% of all malformations among live-born infants. And it's even more severe in pregnancies that don't go to term. The incidence among stillborns is a staggering 10 times higher.
The vast majority of these defects have multifactorial causes. We're talking about a complex interplay between genetic and environmental influences that happen to strike during that delicate 10-day developmental timeline we talked about earlier. Some high-yield teratogens you should know are the rubella virus and chemicals like thalidomide, retinoic acid, and alcohol. Maternal diseases like insulin-dependent diabetes and hypertension are also significant risk factors. Plus, chromosomal abnormalities and genetic syndromes with craniofacial components, specifically DiGeorge, Goldenhar, and Down syndromes, are highly associated with heart malformations.
Section 6. Atrial septal defects, pathology. Let's focus our clinical lens specifically on atrial septal defects, or ASDs.
We're going to apply all the anatomical knowledge we just learned directly to clinical diagnosis. ASDs are pretty common congenital anomalies, showing up with an incidence of about 6.4 per 10,000 births. Interestingly enough, they have a 2-to-1 prevalence in female to male infants. Now, we can actually categorize these defects based on exactly which embryological structure failed. For example, an ostium secundum defect is caused by either way too much cell death and resorption of the septum primum or by the septum secundum just inadequately developing. An ostium primum defect, on the other hand, is fundamentally a failure in the endocardial cushions themselves. And in the absolute most severe cases, you can get a common atrium, which occurs when there is just a complete absence of the septa.
So, the crucial takeaway is right here. You can visually see the pathology. Look at image B, for instance. You can clearly see how excessive resorption of the septum primum creates this massive pathological gap that the septum secundum just cannot cover. Or look at image D, where the total absence of the septum secundum leaves the ostium secundum completely wide open. When you know the normal tissue growth patterns, the mechanism of the defect suddenly makes perfect visual sense.
All right, I want to end today's explainer by leaving you with a bit of a provocative thought to ponder. We know that right-to-left shunting through the atria is absolutely essential for a fetus to survive in the womb. But if a child is born with a common atrium, meaning a completely absent atrial septum, how might that lack of separation ultimately compromise the hemodynamics and the entire cardiovascular system the very moment that newborn takes its first breath and pulmonary resistance drops? Think through the physiology of the anatomy you just mastered. Thank you so much for joining me for this explainer. Keep learning, keep questioning, and I'll see you next time. Welcome to the explainer. Today, we're going to dive right into the absolutely fascinating, highly dynamic 3D morphological changes of the developing heart. Now, as second-year med students, you already know that mastering cardiac embryology isn't just about rote memorizing a timeline, right? It's really about building this robust, three-dimensional mental model of how these structures actually form, fuse, and twist. And, just as importantly, we need to understand exactly what happens clinically when those intricate little steps go wrong.
Here is our roadmap for this explainer. 1. The endocardial cushions. 2. Conotruncal septation. 3. Neurocrest cells. 4. Clinical pathologies. And 5. A high-yield review.
All right, let's jump straight into Section 1, the endocardial cushions, which really form the foundation of cardiac separation.
So the absolutely crucial takeaway here is that these endocardial cushions have 4 distinct vital jobs in creating a properly separated 4-chambered heart. First up, they divide the atrioventricular canal into a right and left orifice. Second, they're entirely responsible for closing the ostium primum. Third, they actually form the membranous portion of the interventricular septum, which is what closes the interventricular foramen. And fourth, they form the normal mitral and tricuspid valves. So really, think of them as the ultimate central anchoring point of the developing heart. And this brilliantly illustrates what's happening by the 7th week. The endocardial cushions are acting as this major central meeting point. Look at how the septum primum is descending right toward them, while the muscular interventricular septum is growing upward to meet them. At the exact same time, you've got the oval foramen and the right venous valve taking shape over in the right atrium, which, as we know, establishes those absolutely necessary shunts for fetal circulation.
Now, what happens if those endocardial cushions fail to fuse entirely? Well, the clinical consequence is a persistent atrioventricular canal. You're left with this massive central defect. Because the cushions basically fail to do all 4 of their jobs, the patient ends up with an atrial septal defect, a ventricular septal defect, and totally abnormal valve leaflets, all sitting in a single, unseparated AV orifice. It is literally a complete failure of that central anchor.
Moving right along to Section 2, conotruncal septation. We're going to explain the twist.
This whole process kicks into gear during the 5th week of development.
and a highly specific sequence absolutely must occur to properly separate our great vessels. First, the right superior and left inferior truncus swellings appear. Second, these swellings start growing distally, right toward the aortic sac. And third, and guys, this is the really critical part, they don't just grow straight down. No, they twist around each other. This is what foreshadows the vital spiral course of the future septum.
Looking at this pristine view of the outflow tract, you can actually see these specific swellings. The right superior and left inferior truncus swellings are growing toward the aortic sac, which connects up to aortic arches 3, 4, and 6. Now, look a bit lower down. The right dorsal and left ventral conus swellings are growing to divide the conus just above the bulboventricular flange. As these conus swellings grow, they divide the conus into an anterior lateral portion, which is going to become the outflow tract of the right ventricle, and a posteromedial portion, which becomes the outflow tract for the left ventricle.
Now, what's really fascinating about this slide is how perfectly the microscopic cross-sections line up with the 3D scanning electron micrograph. You can literally see these dense, cellular, truncal, and bulbar ridges, highlighted here in red and teal, physically pushing together to divide that single tube into two distinct channels. It just highlights how incredibly physical and mechanical this entire embryological process truly is.
As these swellings grow and fuse, they twist around each other, almost like a spiral ribbon, and this forms the aorticopulmonary septum. This beautiful, elegant, spiraling mechanism is exactly what ensures the aorta connects securely to the left ventricle and the pulmonary artery connects to the right ventricle. Think about it. If they just drop straight down without that twist, our entire circulatory system would be completely backward. No way that works.
Okay, Section 3, neural crest cells. These are our biological drivers.
None of this complex spiraling happens by magic. The real drivers moving behind the scenes are the neural crest cells. These specialized cells are absolutely essential for proper outflow tract formation. They actively migrate directly into the conus cordis and truncus arteriosus to contribute to the endocardial cushion formation in this specific region. If their migration, their proliferation, or their differentiation is abnormal in any way, the entire conotruncal septation sequence just completely falls apart. And this brings us to a massive, high-yield board concept you absolutely need to know. Because these exact same neural crest cells also contribute extensively to craniofacial development, it is highly, highly common to see facial abnormalities and cardiac abnormalities simultaneously in the same patient. So if you're reading a clinical vignette featuring a newborn with, say, a cleft palate or micrognathia, and they also have a severe heart murmur, your mind should immediately jump to a neural crest cell migration defect.
Let's move on to Section 4, clinical pathologies. We'll break down the conotruncal defects. First up is the classic tetralogy of fallout. Now, embryologically, this is caused by an unequal division of the conus truncus, which is a direct result of the anterior displacement of the conotruncal septum. Because that septum shifts anteriorly, it creates four strict anatomical components: pulmonary stenosis, an overriding aorta that sits directly above the septal defect, an interventricular septal defect, and finally, secondary hypertrophy of the right ventricle as it struggles to pump against that stenotic pulmonary valve. Clinically speaking, you've got to connect this anterior displacement and unequal division to the cyanotic tet spell. Infants with tetralogy of Fallot will suddenly exhibit bluish skin, cyanosis, especially during episodes of crying or feeding. Why? Because oxygen demand spikes, and right-to-left shunting drastically increases through that VSD. So, what if the conotruncal ridges failed to fuse entirely, rather than just dividing unequally? Well, then you get persistent truncus arteriosus. You're left with a single, large, common truncus that supplies the systemic, the pulmonary, and the coronary circulations all at once. The pulmonary artery originates right off this common trunk. And because the septum in the truncus and conus completely fail to form, this abnormality is always, and I mean always, accompanied by an interventricular septal defect.
Here we see our third major anomaly, transposition of the great vessels. Look really closely at how the vessels are routed here. The aorta is originating directly from the right ventricle, and the pulmonary artery originates from the left ventricle. This creates two completely parallel, closed-loop circulations, and honestly, that is totally incompatible with life unless there is some kind of mixing point. To survive, the infant requires either an open patent ductus arteriosus or a patent oval foramen just to allow some oxygenated blood to cross over.
Now, to keep these distinctly straight in your head for your exams, focus on the specific embryological mechanism of failure. Persistent truncus arteriosus is a failure of the ridges to fuse at all. Transposition of the great vessels, on the other hand, is a failure of the conotruncal septum to follow its normal spiral course. It forms, sure, but it just runs straight down.
It's the exact same region, but completely different mechanical failures.
Let's wrap things up with Section 5, High-Yield Exam Review. Okay, here is your rapid-fire summary. Lock these in. Number 1. The endocardial cushions close the ostium primum and form the membranous interventricular septum. 2. Truncus swellings must spiral during the 5th week to properly orient the outflow tracts. 3. Neural crest cell anomalies link craniofacial defects directly with conotruncal heart defects. 4. Tetralogy of Fallot is caused by unequal division of the conus via anterior displacement. And 5. Transposition of the great vessels occurs when the septum forms but totally fails to spiral.
I'm going to leave you with this final, crucial tip. To truly master embryology, you can't just memorize a list of diseases. When you see a defect in a newborn, you have to ask yourself exactly what cellular swelling failed, and in exactly what week, to cause this anatomical variance. Trace the clinical defect backward to its microscopic origin. When you can explain the why behind the what, you're not just going to pass your board exams, you're going to become an excellent physician. Which really leaves us with a profound question. If the microscopic migration of a few neural crest cells can dictate the architecture of our heart and face so completely, what other hidden cellular journeys ultimately define human survival? Thanks so much for joining me on this explainer, and keep studying smart.
All right, welcome to this explainer. Let's dive straight in. Today we're tackling a beautifully intricate and highly tested topic, the embryology of the cardiovascular system, with a laser focus on vascular development. Whether you're a second-year med student grinding for board exams or just someone fascinated by how the human body builds itself, this comprehensive walkthrough is going to give you the exact structural foundations you need. We are literally going to build this system from a single cell all the way up to a fully functioning fetal heart, and then see exactly what happens the moment a newborn takes its first breath. So here's our roadmap for today. First, vascular development mechanisms. Then, the aortic arches, followed by the aortic arch derivatives. Fourth, we'll trace the fetal circulation pathway. Fifth, postnatal vascular changes, and we'll wrap it all up with some highly yield clinical correlates. We're taking this step by step, making sure absolutely no detail gets left behind.
Kicking things off with Section 1, Vascular Development Mechanisms. This is our starting point, because, before we can even talk about a beating hearts or complex arteries, we have to understand how a simple tube of blood forms in the embryo in the first place.
Now, you'll definitely want to star this in your notes because it's a crucial exam distinction right out of the gate. Blood vessel development happens via two totally distinct mechanisms. First, we have vasculogenesis. This is the creation of brand new vessels from scratch. They arise directly from the coalescence or clumping together of precursor cells known as angioblasts. On the flip side, we have angiogenesis. This is when new vessels simply sprout from already existing ones. I always like to think of vasculogenesis as laying down the main major highways across empty land, while angiogenesis is building out all the local side streets that branch off of those highways.
Moving right along to Section 2, Development of Aortic Arches, our blueprint. Let's fast forward a bit to the 4th and 5th weeks of embryonic development to see how our structural blueprint really begins to take shape. This is the critical window when the pharyngeal arches form, setting the stage for all the major arteries of the head, neck, and chest. During this early window, the organization here is just incredible. Each pharyngeal arch receives its very own cranial nerve and its very own artery. We call these arteries the aortic arches. They sprout directly from the aortic sac, which is actually the most distal part of the primitive heart tube. You might know it as the truncus arteriosus. So these vessels are embedded deep in the mesenchyme of the arches, and they terminate in the right and left dorsal aorta. But here's the catch. They don't pop up all at once. They develop in a strict cranial to caudal sequence, meaning from the head downwards. There are 5 arches in total, numbers 1, 2, 3, 4, and 6. Wait a second. Where's number 5? Well, the 5th arch either never forms at all, or it briefly forms and immediately regresses. Nature's funny like that.
Okay, on to Section 3, Aortic Arch Derivatives. We're mapping the arteries now. The most heavily tested concept in this whole area is matching those embryonic arches we just talked about to their permanent adult arterial derivatives. The human body is incredibly efficient, basically recycling and remodeling these temporary arches into a permanent vascular network.
Let's break down this matrix of high-yield derivatives you absolutely have to memorize. Arch 1 gives rise to the maxillary arteries. Arch 2 forms the hyoid and stapedial arteries. Now, Arch 3 is massive. It forms the common carotid arteries and the first part of the internal carotid arteries. And pay close attention here.
The external carotid arteries actually sprout directly from this third arch as well. Arch 4 is a bit asymmetrical. On the left side, it forms the actual arch of the aorta, sweeping from the left common carotid down to the left subclavian. But on the right side, it forms the proximal portion of the right subclavian artery. Finally, arch 6. This is our pulmonary arch. On the left, it forms the left pulmonary artery and the incredibly vital ductus arteriosus. On the right, it simply forms the right pulmonary artery.
When you visualize how this all connects, the pieces of the puzzle really start falling into place. You can see how the proximal portion of the aortic arch derives from the left horn of that embryonic aortic sac, while the right horn of the sac becomes the brachiocephalic artery. And remember those subclavian arteries? The distal portion of the right subclavian, along with the left subclavian, actually develop from the 7th intersegmental arteries on the respective sides. It is a wildly complex, beautifully orchestrated remodeling process.
Now, here's the wild part. To get to that clean, final adult form, the body actually has to tear down some of the scaffolding. First, the dorsal aorta between the entrance of the 3rd and 4th arches, which we call the carotid duct, is completely obliterated, gone. Second, the right dorsal aorta disappears entirely between the origin of the 7th intersegmental artery and its junction with the left dorsal aorta. At the same time as the embryo grows, the carotid and brachiocephalic arteries elongate considerably. So the really crucial takeaway here is that as the heart shifts caudally, or downwards into the chest cavity, and these specific arches disappear, it essentially drags the recurrent laryngeal nerves into an asymmetrical course. The right recurrent nerve hooks around the right subclavian artery, while the left nerve gets pulled way further down, hooking under the ductus arteriosus.
Which brings us to Section 4, Fetal Circulation Pathway, the system in motion. We're shifting gears now from morphological growth to physiological function. Before birth, the fetal lungs aren't breathing air, and the liver doesn't need to process nutrients from the gut. So we're going to trace the exact journey of a single drop of fetal blood to see exactly how the system adapts.
Let's walk through it step by step. It all starts at the placenta. Highly oxygenated blood, we're talking about 80% saturated with oxygen, travels toward the fetus through the single umbilical vein. As it approaches the liver, most of this blood short-circuits the liver completely. It flows through a vital shunt called the ductus venosus, emptying straight into the inferior vena cava. Now, a tiny amount does enter the liver sinusoids to mix with portal blood, but the main flow is actually regulated by a critical sphincter mechanism right in the ductus venosus. If a sudden uterine contraction pushes venous return too high, this sphincter clamps down, which prevents a dangerous, sudden overloading of that tiny, developing fetal heart. It's a built-in safety valve.
As that rich, oxygenated blood hits the heart, it's guided by the anatomical valve of the inferior vena cava, which acts kind of like a traffic cop. It directs most of this blood into the right atrium, and then straight through a literal hole in the heart wall, the oval foramen, directly into the left atrium. From there, it goes to the left ventricle and shoots up into the ascending aorta. This is just brilliant engineering. Why? Because the coronary and carotid arteries are the very first branches off the ascending aorta. That means the developing heart musculature and the rapidly growing brain are being supplied with the absolute most highly oxygenated blood available in the entire system.
But wait, not all of the blood makes it through that oval foramen. The lower edge of the septum secundum, a little physical wedge called the crista dividens, catches a small amount of that placental blood. It prevents it from crossing over and drops it into the right atrium instead. Here, it mixes with desaturated, oxygen-poor blood that's returning from the fetal head and arms via the superior vena cava.
So this newly mixed blood drops into the right ventricle and gets pumped out into the pulmonary trunk, heading straight for the lungs. But remember, the fetal lungs are completely collapsed and filled with amniotic fluid. Because of this, the fetal pulmonary vessel resistance is incredibly high. It's like trying to push water through a closed door. So the blood takes the path of least resistance. It's forced through our second major shunt, the ductus arteriosus, dumping directly into the descending aorta, completely bypassing those non-functional lungs.
Once it's in the descending aorta, this blood mixes with the flow coming from the proximal aorta. By the time this blood courses all the way down the descending aorta and reaches the two umbilical arteries, heading back to the placenta to get reoxygenated, its oxygen saturation has plummeted to roughly 58%.
All right, Section 5, Postnatal Vascular Changes. This is the climax at birth. The moment of birth serves as a dramatic, permanent transition. The very first breath a baby takes permanently alters this entire vascular landscape in literally a matter of seconds. The moment the infant breathes, the lungs expand, and that massive pulmonary vascular resistance we just talked about, It drops off a cliff. Suddenly, blood rushes freely into the lungs rather than bypassing them, and right away we see the immediate functional closure of the fetal shunts and umbilical vessels. The placenta is snipped out of the circuit, which prompts a total, permanent rerouting of systemic pressures. It is an incredibly profound physiological shift.
Now, you've absolutely got to lock these into your memory for exam day. You must know the exact adult derivatives of these closed fetal structures. The umbilical arteries close up to become the medial umbilical ligaments. The umbilical vein closes to form the ligamentum teres hepatis, right there in the lower margin of the falciform ligament. The ductus venosus, that becomes the ligamentum venosum of the liver. The ductus arteriosus constricts down and becomes the ligamentum arteriosum. And finally, that flap of the oval foramen snaps shut tightly against the septum, eventually fusing completely to become the fossa ovalis. Finally, Section 6, Clinical Correlates. Let's ground all of this elegant developmental theory in a highly tested clinical application. Because what actually happens when these perfect little timelines fail? A textbook example of this is a patent ductus arteriosus, or PDA. If that ductus arteriosus fails to close up after birth, it remains patent, which just means open. This is actually one of the most frequently occurring abnormalities of the great vessels. It's especially prevalent in premature infants, mainly because their tissues just aren't mature enough to respond to the drastic oxygen and pressure changes of birth. A PDA can happen as a totally isolated, standalone defect, or it might accompany and sometimes, fascinatingly, even compensate for other really severe congenital heart defects.
Because aortic pressure naturally becomes much higher than pulmonary pressure right after birth, a patent ductus arteriosus will actually cause oxygenated blood to flow backwards, from the aorta back into the pulmonary artery. This creates a left-to-right shunt, severely overworking the lungs and the left side of the heart. So, as we wrap up this explainer, I want to leave you with a question. How does the failure of this single, tiny embryonic mechanism alter adult hemodynamics years down the line? Let that curiosity drive your clinical studies forward. Understanding the normal embryological blueprint is truly the only way to master the abnormal. Keep reviewing these foundational concepts, and I'll catch you in the next explainer.
All right, welcome to this explainer on respiratory embryology. Today we're setting up a premium step-by-step atlas review of respiratory development specifically geared for your second-year modules. If you've ever found yourself totally lost trying to figure out how a tiny, flat cluster of cells folds, divides, and somehow expands into a fully functioning set of lungs, well, you're in exactly the right place. We're going to build your foundational understanding from the ground up, making absolutely sure you not only know the normal anatomical milestones, but exactly why and how things can go wrong clinically. Let's get into it.
Here's our roadmap for today. First, we'll look at the respiratory diverticulum. Second, tracheo-esophageal partitioning. Third, a high-yield clinical focus on TEFs and Vactorol. Fourth, laryngeal and bronchial development. And finally, number 5, pleural cavity formation.
Okay, let's dive right into part 1, the respiratory diverticulum.
So our whole process kicks off right around the 4th week of development with the appearance of the respiratory diverticulum, or, more simply, the lung bud. Notice how this bud forms as the direct outgrowth right from the ventral wall of the foregut. And at this initial stage, it's absolutely crucial to realize that this lung bud isn't just some isolated island. It's actually in wide open communication with the foregut. They're essentially sharing the exact same space. Now, because the lung bud pops up exactly where it does, we absolutely have to talk about tissue origins. And listen up, because this is a massively high-yield concept for your board exams. These structures aren't just built from a single embryonic layer. The internal epithelial lining, so think the inner surface of the larynx, the trachea, the bronchi, and the lungs, that is entirely endodermal in origin. It takes its cues straight from that foregut connection. But as you know, a hollow tube isn't going to hold up on its own, right? An airway needs serious structure, it needs support, and it needs muscle. That is exactly where the splanchnic mesoderm comes into play. It surrounds the endoderm and actually gives rise to the cartilaginous, muscular, and connective tissue components of the trachea and lungs. So it's really these two totally separate origins combining perfectly to build one functional system.
Moving right along to part 2, tracheo-esophageal partitioning. So the embryo has to safely separate this brand new airway from the digestive tract. And it does this through a beautifully elegant mechanism of progressive spatial partitioning. Here is how it breaks down. Step 1. 2 longitudinal tracheo-esophageal ridges appear on the inside of the tube. Then, step 2, these ridges actually grow toward each other and eventually fuse to form a solid barrier.
We call that barrier the tracheoesophageal septum. And finally, step 3. This newly formed septum completely divides that original foregut into two very distinct sections. You get a dorsal portion, which becomes the esophagus, and a ventral portion, which becomes the trachea and those expanding lung buds.
During this spatial split, you can see how the septum essentially zips down, neatly organizing the ventral respiratory structures completely away from the dorsal digestive tract. It's a brilliant piece of engineering. Once this partitioning is totally complete, the respiratory primordium only maintains communication with the pharynx way up top, exclusively through the laryngeal orifice. The permanent boundary is officially set.
Which brings us to part 3, our clinical focus on TEFs and Vactoral. Now, what happens when this partitioning fails? Well, when the tracheoesophageal septum doesn't form perfectly, we see some highly significant clinical abnormalities. Specifically, these failures result in esophageal atresia, which can happen with or without tracheoesophageal fistulas, or TEFs for short. These fistulas and those blind-ended pouches basically happen for one of two reasons. Either there's a spontaneous posterior deviation of the septum itself, or some external mechanical factor literally pushes the dorsal wall of the foregut anteriorly during development. Either way, the normal spatial geography is totally compromised.
Okay, I want you to treat this right here as a critical exam interlude. You see, TEFs rarely just happen in a vacuum. They're frequently part of a package deal called the Vactoral Association. This is an acronym you absolutely 100% must commit to memory. It stands for vertebral anomalies, anal atria, cardiac defects, tracheoesophageal fistula, esophageal atria, renal anomalies, and limb defects. The really important thing to note here is that Vactoral is a collection of defects with an unknown causation, but they occur together way more frequently than you could ever predict by random chance alone.
Let's anchor that TEF pathology we just covered into this broader Vactor picture. Imagine you're examining a newborn infant who presents with choking and regurgitation the very first time they feed. Now, those are classic, textbook signs of an esophageal atresia, or a TEF. But your job as a physician isn't done just because you identified the airway issue. You have to systematically evaluate the infant's spine, check for anal patency, listen to their heart, order a renal ultrasound, and carefully examine their limbs. These interconnected bodily systems are basically a package deal when that early embryological mapping goes awry.
And speaking of evaluating those interconnected systems, I really want to boldly emphasize this one specific statistic for you. 33%. 33% of these tracheoesophageal fistula cases present with associated cardiac abnormalities. That is a full third of your patients. To put that into perspective, it tells you exactly how absolutely vital a thorough cardiac workup is the second you diagnose any airway partitioning defect.
All right, shifting gears back to normal development. Here is part 4, laryngeal and bronchial development. Starting all the way at the top, the laryngeal orifice goes through a pretty massive makeover. It morphs from just a simple sagittal slit into a definitive T-shaped opening. But honestly, the incredibly testable facts here are the mesenchyme and neurological origins. Remember how we talked about the splanchnic mesoderm earlier? Well, the musculature and cartilages of the larynx specifically derive from the mesenchyme of the 4th and 6th pharyngeal arches. And because of that exact embryological origin, all of the laryngeal muscles are innervated by the cranial nerve that's associated with those specific arches, which is, of course, the vagus nerve.
Let's move down to the lower airway and see how this all builds out. By the time we hit the beginning of the 5th week, we start seeing some rapid expansion. Those initial lung buds enlarge significantly and form the right and left main bronchi. So we're finally moving from just simple little outgrowths into a true, recognizable, branching tree structure.
And right here at week 5, a really essential asymmetry gets established. One that perfectly foreshadows the adult anatomical lungs. Check this out. The right main bronchus forms 3 secondary bronchi, which are eventually going to supply the 3 lobes of the right lung. Meanwhile, the left main bronchus forms only 2 secondary bronchi, completely destined to become the 2 lobes of the left lung. So the structural blueprint for your adult respiratory capacity, it is literally locked in by week 5.
And finally, part 5, pleural cavity formation. Let's make sure we have a perfect mental model of the embryological geography here. The body cavity at this early stage, it is definitely not just a massive open space. The expanding lung buds are actually growing into what we call the pericardioperitoneal canals. These are very narrow spaces situated right on each side of the foregut.
You can really appreciate the spatial dynamics here when you look at it in a transverse orientation.
With subsequent growth, the lung buds don't just, grow straight outward. Their growth vectors expand in downward and lateral directions. And as they push downward and laterally, they gradually fill up those narrow pericardioperitoneal canals that are lying alongside the foregut.
Now, as these lungs push into those canals, they interact with the surrounding mesodermal linings to actually form the pleurae. The mesoderm that directly covers the outside of the expanding lung tissue itself, that develops into the visceral pleura. Conversely, the somatic mesoderm layer that covers the inside of the body wall, that becomes the parietal pleura. And the tiny space that remains right between this newly formed parietal and visceral pleura is exactly what becomes the definitive pleural cavity.
As we wrap up this explainer, I just want you to step back for a second and marvel at this foregut connection. It is honestly kind of wild to think that both our ability to breathe and our ability to digest food originate from the exact same primitive endodermal tube. Mastering this shared embryological origin isn't just about memorizing weeks and germ layers for test, it is the master key. It unlocks your understanding of perfectly adapted normal anatomy, and it gives you the precise logic you need to decode devastating clinical pathologies like fistulas and atrasias when that delicate timeline goes off track. Think about it. How might disruptions in this single tube early on predispose a patient to lifelong physiological challenges? I want you to keep that question lingering in your mind as you move forward in your medical studies. Thanks for joining me.
Welcome back, medical students, to another explainer. Today, we're zeroing in on mastering the final stages of respiratory embryology. We'll be picking up exactly where the initial lung buds leave off and tracing that fascinating journey from microscopic maturation all the way through birth and finally into postnatal growth. Now, this is a highly testable area. It's packed with precise timelines, critical cellular changes, and some really vital clinical correlations. So grab your notes, get focused, and let's master the embryology of the lungs together.
Okay, let's dive right into this. Here's our roadmap for today. First, bronchial tree development. Second, maturation of the lungs. Third, fetal fluid and surfactant. Fourth, birth and postnatal growth. Fifth, a critical clinical correlate on RDS. And finally, we'll wrap up with a summary and some high-yield exam tips.
Starting off with Part 1, bronchial tree development, focusing specifically on division and generations. It's really fascinating to trace the precise, almost mathematical nature of lung development. The lung buds develop into secondary bronchi, and from there they divide repeatedly in a dichotomous fashion, meaning they literally split into two branches at every single step. This incredibly precise branching is what forms the bronchopulmonary segments of the adult lung. You end up with exactly 10 tertiary or segmental bronchi in the right lung and 8 in the left. Now pay close attention to the timeline here. By the end of the 6th month of prenatal development, about 17 generations of these subdivisions have already formed. But the bronchial tree isn't actually finished yet. Before it reaches its final adult shape, an additional 6 divisions are going to form during postnatal life. Moving right along to Part 2, maturation of the lungs, and the 4 distinct periods of development. The microscopic maturation of the lungs is strictly divided into 4 histological periods, and you really need to lock down these timeframes for your exams. First up is the pseudoglandular period, running from 5 to 16 weeks. During this time, branching continues to form terminal bronchioles, but, and this is a huge but, no respiratory bronchioles or alveoli are present yet. Respiration is absolutely impossible at this stage. Next, we enter the canalicular period, from 16 to 26 weeks. Here, the bronchioles are dividing continuously into more and smaller canals. Every terminal bronchiole divides into 2 or more respiratory bronchioles, which then split into 3 to 6 alveolar ducts. The vascular supply is also steadily ramping up. Then comes the terminal sac period, spanning from 26 weeks all the way to birth. This is where terminal sacs, or primitive alveoli, form, and the surrounding capillaries establish incredibly close contact with them. Finally, the alveolar period kicks in from 8 months postnatally and extends well into childhood. This is when mature alveoli develop those perfectly established epithelial-endothelial capillary contacts. And this comparison brilliantly illustrates exactly what's happening at the cellular level during these shifts. In the earlier canalicular phase, you have this really thick cuboidal epithelium lining the respiratory bronchioles. Gas exchange just isn't happening across cells that thick, right? But as development marches on, some of these cuboidal cells flatten out dramatically, becoming what we call type 1 alveoli epithelial cells. They transform into extremely thin, squamous epithelial cells, allowing the blood capillaries to sit right up next to them. Which brings us to a massive physiological game changer, the creation of the blood-air barrier. The definition here is absolutely key. It's the intimate contact established when those type 1 alveolar epithelial cells become so extremely thin that they allow the surrounding capillaries to physically protrude into the alveolar sacs. This incredibly close contact between the lung's epithelial cells and the capillary endothelial cells is the barrier itself. Because this barrier forms, and because enough capillaries are finally present during the 7th month, gas exchange becomes adequate. This is the exact embryological reason why a premature infant born during the 7th month actually has a physiological chance to survive.
All right, part 3, fetal fluid and surfactant. How the body prepares for that very first breath. Now, you might think the lungs are just empty balloons before birth, but actually, they are completely full of fluid. And it's not just water. This fetal fluid is a highly specific cocktail made of 4 main ingredients. You've got a very high chloride concentration, very little protein, some mucus secreted by the bronchial glands, and crucially, surfactant produced by the alveolar epithelial cells. Plus, did you know fetal breathing movements actually start well before birth? It's true. These movements cause the fetus to aspirate amniotic fluid. It's not a glitch in the system, it's totally essential for stimulating lung development and for conditioning the respiratory muscles so they're strong enough to do the heavy lifting the second that baby is born.
So, we just mentioned surfactant. Let's define this perfectly because it's literally one of the most important concepts in respiratory embryology. Surfactant is a fatty phospholipid coat. Now remember those thin type 1 cells we talked about earlier. They're built for gas exchange. But a completely different cell type, the type 2 alveolar epithelial cell, is the one responsible for churning out this surfactant. These type 2 cells really start developing at the end of the 6th month of prenatal life. The amount of surfactant in the fetal lung fluid slowly builds up, but then it spikes significantly during the last 2 weeks before birth. Its main job? To prevent the alveoli from snapping shut and collapsing completely during expiration, a really dangerous condition known as atelectasis.
Which leads us to part 4, birth and postnatal growth, the big transition to air breathing.
Picture the exact moment of birth. An incredible, perfectly timed sequence of mechanical steps has to execute flawlessly. Step 1. The vast majority of that fetal lung fluid is rapidly resorbed by the surrounding blood and lymph capillaries. Step 2. As that fluid drains away, the surfactant doesn't just wash out with it. It stays behind, remaining deposited right there as a thin, protective phospholipid coat resting directly on the alveolar cell membranes. Step 3. Respiratory movements bring air into the lungs for the very first time. The lungs expand, filling the pleural cavity. And because that fatty surfactant layer is sitting there, it prevents the development of an air-water interface with high surface tension. Without it, the high surface tension would cause those tiny alveoli to just collapse and stick together every single time the newborn exhaled.
So here's a wild fraction for you, 1/6. It's estimated that only about 1/6 of the total adult number of alveoli are actually present at the moment of birth. Which naturally leads to the question, if only 1/6 are there at birth, when exactly do the rest of them show up? The magic number here is 10. The remaining alveoli are formed during the first 10 years of postnatal life. So the main growth of the lungs after birth isn't just the existing cells getting bigger. It's driven by a massive, continuous increase in the absolute number of respiratory bronchioles and brand new primitive alveoli over the entire first decade of a child's life.
Next up, part 5, a clinical correlate on RDS, or respiratory distress syndrome.
So how does all this embryology actually translate to patient care in the neonatal intensive care unit? Well, RDS happens when a premature infant is born before their type 2 alveolar cells have had the chance to produce enough surfactant. Without it, their alveoli collapse, leading to severe, life-threatening respiratory distress. But directly manipulating these embryological pathways has totally revolutionized medicine. The development of artificial surfactant, which can be delivered right into a premature baby's lungs, combined with treating mothers with glucocorticoids before a premature delivery to actively kickstart fetal surfactant production, it's been a total game changer. It has drastically reduced RDS mortality. Because of these interventions, we're now seeing the survival of some babies born as incredibly early as 5.5 months of gestation.
And finally, part 6, our summary and exam tips. Time for a high-yield review.
All right, rapid fire time. Lock these 5 textbook concepts in for your exams. Number 1, macroscopic branching features, 17 prenatal divisions by month 6, but remember, it adds 6 more postnatally. Number 2, gas exchange depends completely on the blood-air barrier, which strictly requires those thick cuboidal cells to flatten out into thin type 1 epithelial cells. Number 3, type 2 cells are entirely separate. They're the ones producing the surfactant, starting late in the 6th month. Number 4, the mechanics of birth.
fetal fluid is rapidly resorbed by capillaries, leaving behind that crucial surfactant to prevent atelectases. And number 5, lung development does not stop at birth. The formation of new primitive alveoli keeps going strong for 10 full years.
And I want to leave you with this final, definitive, and heavily tested physiological fact. Mature alveoli are not present before birth. Don't let tricky board questions fool you into thinking lung development is all wrapped up in utero. The lungs are constantly developing, constantly adapting, from that very first microscopic lung bud all the way through the first decade of life. So, what does this constant state of ongoing adaptation tell us about the sheer resilience of human development? It's something to think about. Keep that structural timeline crystal clear in your mind, and you will absolutely ace your embryology exams. Keep studying hard, and we'll catch you in the next explainer.
All right, let's jump right into this explainer. Today we're tackling a really fascinating structural puzzle, the embryology of the digestive system, and specifically the architectural blueprint of the gut. Imagine you've got a completely flat, two-dimensional embryonic disc, right? And your job is to transform that flat disc into a highly complex, three-dimensional digestive tract, all neatly packaged inside a closed body cavity. It's honestly an extraordinary feat of biological engineering. And by the end of our time together today, you're going to understand exactly how it all comes together.
Here is our roadmap for the breakdown. First, the embryonic folding process. Second, divisions of the gut. Third, the primitive gut tube. Fourth, adult gut derivatives. Fifth, the dorsal mesentery. And finally, number 6, the ventral mesentery.
So let's start by posing our first core architectural problem. How exactly do we get a ventral body wall? Just think about it for a second. How does a totally flat embryo physically close itself off from the outside world to protect the internal structures developing inside?
And then layer a second conundrum right on top of that. How do we get a gut within a cavity? Like, how do we create this enclosed, suspended internal tube right down the middle of that newly formed body wall while still maintaining a highly organized blood supply?
Okay, let's dive into Section 1, the embryonic folding process.
The answer to both of those architectural questions? It's embryonic folding. Now, this is absolutely crucial. This process happens precisely in the 4th week of development. If you're studying for the boards, definitely lock that timeline in, the 4th week. During this window, the embryo is actually folding simultaneously in 2 different directions. It folds laterally, so side to side, and craniocaudally, from head to tail. And it's this dual folding action that ultimately creates our 3D 2D structure.
Let's walk through exactly how this happens. As the embryo folds laterally, meaning the left and right margins fold downward and inward toward the midline, it's essentially pinching off the top portion of the yolk sac. Once those lateral edges meet and fuse together, boom, you have a closed ventral body wall. And at the exact same time, that pinched off portion of the yolk sac gets incorporated right inside the embryo, completely transforming the primitive gut into a proper tube.
Now, let's think about the longitudinal axis. While that side-to-side lateral folding is going on, craniocaudal folding is happening at the exact same time. The head and tail ends of the embryo are curving sharply downward. And this specific fold creates these really distinct cranial and caudal pockets from the yolk sac endoderm. This is the true beginning of our primitive gut development, literally defining where the top and bottom of our digestive tract are going to be.
When you put both spatial dimensions together, it perfectly locks in that 3D anatomical orientation. The lateral folding gives us the central tube and the anterior body wall, while the craniocaudal folding gives us those longitudinal boundaries. Together, these simultaneous movements take us from a flat disc to an enclosed cylindrical embryo with a gut tube running right down the middle.
Moving right along to Section 2, divisions of the gut, foregut, midgut, and hindgut.
All right, now that our basic 3D tube is formed inside the body cavity, we can start identifying its specific functional compartments. We essentially divide the gut into 3 distinct regions: the foregut, the midgut, and the hindgut. Now pay attention to a crucial structural difference here. The foregut and the hindgut both start out as blind-ending diverticula, meaning they're completely closed off at their ends. But the midgut, it actually maintains a wide open connection to the yolk sac temporarily. And it is vital to remember that these 3 embryonic divisions directly dictate the specific blood supply and lymphatic drainage for the entire adult digestive system later on.
Section 3, the primitive gut tube. We'll be looking at the endoderm and mesoderm.
So the crucial point here is defining the strict physical boundaries and the exact cellular origins of the tube we just built. And you absolutely need to know which embryonic layers form which part of the gut. This is extremely high yield for exams. The internal lining of the primitive gut tube is derived exclusively from endoderm. That endoderm becomes all of your future epithelial linings. Conversely, the external lining comes from splenchnic mesoderm. This mesodermal layer is what develops into the future musculature of the gut wall, as well as the visceral peritoneum that wraps right around it.
The development of this tube actually kicks off in the 3rd week, when it starts pinching off from the yolk sac cavity, and the full tube runs all the way from the stomatodium, which is the future mouth, up rostrally, straight down to the proctodium, the future anus, down caudally. Also notice that the gut tube is suspended right in the middle of the intraembryonic column. It doesn't just float there, it's held securely in place by a double layer of that splanchnic mesoderm we were just talking about.
Which brings us to Section 4, Adult Gut Derivatives. Let's map out the adult gut.
Now that we have a solid grasp on the embryonic blueprint, let's translate these early divisions directly into adult clinical anatomy. This overarching spatial layout perfectly illustrates how our mature organs map back to their embryological roots. The foregut, the midgut, and the hindgut each spawn a specific set of organs. And having this mental map is essentially a cheat sheet for understanding adult vascular supply, because the main arteries supplying your adult organs correspond exactly to these 3 early embryonic divisions.
Let's methodically trace the exact borders here. The foregut gives rise to the esophagus, the stomach, the pancreas, liver, gallbladder, and critically, the duodenum, but only proximal to the entrance of the bile duct. Then the midgut picks up right from there, from the duodenum distal to the entrance of the bile duct, and gives us the jejunum, the ileum, the cecum, the ascending colon, and precisely the proximal 2/3 of the transverse colon. Finally, the hindgut finishes out the tract. It derives the distal 1/3 of the transverse colon, the descending colon, the sigmoid colon, the rectum, the upper anal canal, and interestingly, even the internal lining of the bladder and urethra.
Next up is Section 5, the dorsal mesentery, and how it suspends the gut tube.
So let's look at how this complex, winding tubular structure actually stays anchored inside the massive abdominal cavity. Initially, the foregut, midgut, and hindgut are basically in broad contact with the mesenchyme of the posterior abdominal wall. But by the 5th week, this connecting tissue bridge narrows down significantly, and this narrowed connection becomes the mesentery. It's a critical collection of connective tissues that physically suspends the gut tube and its derivatives, keeping them all in their proper normal anatomical positions.
Focus specifically on the dorsal mesentery, which points straight down from the back wall. This structure has a big job. It suspends the caudal part of the foregut, the entire midgut, and a major part of the hindgut directly from the posterior abdominal wall. And this setup is exactly what allows the intestines to be mobile without just tangling up into a huge knot.
You'll really want to commit the 4 regional structures derived from the dorsal mesentery to memory. First, in the region of the stomach, it forms the dorsal mesogastrium, which eventually becomes the greater omentum. In the duodenum, it forms the dorsal mesoduodenum. In the colon, it forms the dorsal mesocolon. And finally, the specific part of the dorsal mesentery that suspends the jejunal and ileal loops is known as the mesentery proper.
All right, our final section, number 6, the ventral mesentery, derived from the septum transversum.
Now let's contrast that massive posterior anchoring system we just covered with the highly restricted anterior connections. Unlike the dorsal mesentery, which runs along almost the entire length of the gut tube, the ventral mesentery is strictly limited. It only exists at the terminal part of the esophagus, the stomach, and the upper part of the duodenum. And importantly, this ventral mesentery is embryologically derived from the septum transversum. This ventral mesentery essentially consists of 2 incredibly important divisions. First, you have the lesser omentum. This structure extends from the lower portion of the esophagus, the stomach, and the upper duodenum directly over to the liver. The second division is the falciform ligament, which extends from the liver completely forward, firmly connecting it to the ventral body wall.
All right, we've successfully built our architectural blueprint, but I want to leave you with a bit of a clinical challenge to chew on before our next explainer. If this intricate, simultaneous, lateral, and craniocaudal folding process creates the very foundation of the human body, what do you think happens when this incredibly delicate physical fusion process fails during that critical 4th week? How do developmental defects at these precise embryonic stages end up manifesting as adult pathology? Keep that strictly in mind as you review today's structures. Thanks for joining me today, and keep studying hard.
Hey everyone, and welcome to this explainer. Okay, let's dive right in. If you're a second-year med student joining us today, grab your notes because consider this your textbook-level masterclass. Today, we're focusing on the absolutely fascinating spatial transformations of the foregut and midgut.
We're going to take that primitive embryonic tube and literally watch it fold, rotate, and fuse into the incredibly complex anatomy of the adult abdomen. I am so pumped to guide you through this, so let's get started.
Here is our quick roadmap for today. We're going to hit the peritoneum and foregut, esophageal development, and stomach rotation. Then we'll tackle the omentum, spleen, and duodenum, followed by the liver and biliary system, before wrapping the whole thing up with a high-yield exam summary.
All right, Section 1, peritoneum and the foregut.
First things first, we need to formally define the peritoneum. Basically, think of it as a continuous serous membrane that lines the entire inner surface of your abdominal cavity and then folds over to reflect onto the organs themselves. The layer in direct contact with the organs, that's the visceral peritoneum. The layer stuck to the abdominal wall is the parietal peritoneum. And when this membrane bridges the gap between an organ and the back wall, it forms what we call peritoneal reflections. Oh, and a quick historical aside, you'll often hear these reflections referred to as ligaments in older texts. To really visualize this, imagine looking at a cross-section of the abdomen. You've got the parietal peritoneum hugging the outer muscular wall and the visceral peritoneum intimately wrapping the intraperitoneal organ right in the center. The vital bridge connecting the two is the mesentery. It physically suspends the gut tube in space, which is absolutely crucial because it creates a highway for blood vessels and nerves to actually reach the developing organs. Meanwhile, tucked entirely behind that peritoneal cavity, you have retroperitoneal organs, firmly fixed to the posterior wall. Keep this 3D spatial arrangement locked in your mind because it's the key to everything we're about to cover. Moving right along to Section 2, development of the esophagus. Now, picture that shared primitive embryonic tube. Very early on, it gets divided by this crucial barrier called the tracheoesophageal septum. This literally splits the foregut into two completely distinct tubes, a ventral portion in the front, which becomes the respiratory primordium, and a dorsal portion in the back for the esophagus. So the esophagus is sitting right behind the developing trachea. Now, initially, the esophagus is super short, but as the heart and lungs descend during development, it has to lengthen incredibly rapidly to keep up. Okay, listen up, because this is a highly tested anatomical distinction. The muscular coat of the esophagus is formed by the surrounding visceral mesenchyme, but it doesn't develop uniformly. It's really a tale of two different segments. The upper two-thirds develops into striated muscle, and crucially, it's innervated by the vagus nerve. Contrast that with the lower one-third, which develops into smooth muscle and gets its innervation from the splanchnic plexus. The big takeaway here? Always link the specific muscle type directly to its nerve supply. It's a classic board exam setup, so make sure you know it cold. But development doesn't always go perfectly according to plan. We've got two classic clinical anomalies to look out for here. Take esophageal stenosis, which you'll typically find down in the lower third. This narrowing can happen from incomplete recanalization of the tube, random vascular abnormalities, or basically any accident that compromises blood flow. Compare that to a congenital hiatus hernia. Remember a minute ago when we said the esophagus has to lengthen rapidly? Well, if it fails to lengthen enough, it physically pulls the stomach right up into the esophageal hiatus, poking through the diaphragm. All right, Section 3. This is a big one, stomach rotation and pathology. The stomach's development is honestly like a crazy 3D puzzle. Step 1, in the 4th week, it just shows up as a fusiform dilation. It's basically just a slight midline bulge in the foregut. Step 2, it undergoes a 90-degree clockwise rotation around its longitudinal axis. So its original left side sweeps around to face anteriorly, and its original right side faces posteriorly. Step 3, and this is the clincher. Because the stomach rotates, the vagus nerves ride along with it. The left vagus nerve now innervates the front, or interior wall, and the right vagus nerve now innervates the back, or posterior wall. And it's not just spinning on one axis. It also rotates front to back, or anteroposteriorly. The original posterior wall actually starts growing way faster than the anterior portion. This differential growth is exactly what creates the greater and lesser curvatures of the stomach. Plus, the caudal or pyloric part shifts over to the right and upward, while the top cardiac portion moves to the left and slightly downward. This final tilt is what gives the stomach its classic diagonal, hammock-like position in the body. So why does this spatial gymnastics matter clinically? Well, it perfectly sets up one of the most common stomach abnormalities in infants, pyloric stenosis. This happens when the musculature right at the pylorus hypertrophies, or becomes severely thickened. Because the exit pathway is mechanically blocked, the infant presents with a classic, highly recognizable sign, projectile vomiting.
It's an immediate, severe blockage, right at the exact junction we just watched develop.
Okay, section 4, the omentum, spleen, and duodenum.
Remember that 90-degree twist of the stomach we just talked about? Well, as it turns, it literally drags the dorsal mesogastrium over to the left. This massive sweeping motion hollows out a brand new hidden space right behind the stomach. This isolated pocket is the omental bursa, otherwise known as the lesser peritoneal sac. And simultaneously, this same rotation pulls the ventral mesogastrium to the right. It's all connected.
Let's ground this in a quick timeline so we don't get lost. Back in the 4th week, as we know, the stomach does its initial fusiform bulge thing. Just 1 week later, boom, week 5, the spleen primordium enters the chat. It starts as a mesodermal proliferation sandwiched right between the 2 leaves of that dorsal mesogastrium, which, remember, is actively being pulled over to the left.
So what's the outcome of all this sweeping? As rotation continues, the dorsal mesogastrium stretches out. The segment between the spleen and the midline swings left and physically fuses to the peritoneum of the posterior abdominal wall. The back leaf degenerates. The end result? The spleen remains an intraperitoneal organ, but it's now securely tethered to the body wall by the leonorenal reflection, and it's hooked to the stomach by the gastrolenal reflection.
And that exact fusion mechanism brings us to a completely crucial board exam definition, secondarily retroperitoneal. Basically, these are organs that started out floating freely, fully covered by peritoneum and suspended by a mesentery, but later got plastered and fused to the back body wall. The pancreas is a perfect example of this. The duodenum, except for the very first part, the duodenal cap, also becomes secondarily retroperitoneal. And here's a super high-yield functional note. Because the duodenum sits right at the border of the foregut and midgut, it boasts a dual blood supply from both the celiac artery and the superior mesenteric artery.
Moving on to our final major system, section 5, liver and biliary development. The liver is super unique, mainly because it's got dual embryological origins. You absolutely have to know this breakdown. The mesotherm of the septum transversum gives us the scaffolding, the hemopoietic cells, the Kupffer cells, and the connective tissue. On the flip side, the liver cords differentiate into the actual functional tissue, the parenchyma or liver cells, along with the lining of the biliary ducts and the gallbladder. Also, keep in mind that the liver's massive hemopoietic function, pumping out blood cells, gradually fades out during the last 2 months of fetal life. Now, when things go awry in the biliary system, we see a whole spectrum of issues. You've got your common, totally harmless variations like alternative liver lobulation, accessory ducts, or even a duplicated gallbladder. Those are usually asymptomatic. But if the biliary ducts fail to hollow out and recanalize from their solid phase, we get extrahepatic biliary atresia. That happens in about 1 in 15,000 live births, and often requires a liver transplant if it can't be surgically bypassed. Even rarer is intrahepatic duct atresia, seen in about 1 in 100,000 births, which can actually be triggered by fetal infections. Okay, home stretch. Section 6, high-yield exam summary. Let's lock in 5 absolute must-know facts for your exams. Number 1, that esophagus muscle and nerve split. Striatum vagus up top, smooth and splanchnic down below. Number 2, the stomach's 90-degree clockwise twist explains exactly why the left vagus is anterior and the right is posterior. Number 3, despite all the fusions happening around it, the spleen remains an intraperitoneal organ. Number 4, the duodenum is secondarily retroperitoneal and grabs a dual blood supply from the celiac and SMA. And number 5, the liver's dual origins from both the septum transversum and the liver cords. To wrap up, here is a golden rule for your practicals and boards. Always, and I mean always, link the spatial rotation of an organ to its final nerve supply and its peritoneal status. Understanding how it moved perfectly explains where it is and what supplies it. If you can picture the movement in your head, the memorization becomes effortless. But I want to leave you with this thought before your next clinical rotation. If a single millimeter-size rotational error early in week 4 can entirely redefine our nervous, vascular, and organ map, what other hidden embryological anomalies might be secretly driving the unexplained clinical presentations you'll see in the wards tomorrow? Thank you so much for joining me on this explainer, and I'll catch you in the next one.